welcome everyone to the DMDU webinar series. This session will be about informing COVID-19 policy under uncertainty. We have with us a number of very interesting panelists. We have with us Dr. Matthew Biggerstaff. He's an epidemiologist at the Centers for Disease Control and Prevention, and he will present on the CDC's initiatives to inform COVID-19 policy. We also have Dr. Michael Runge. He's a decision analyst and research ecologist at the U.S. Geological Survey Eastern Ecological Science Center. We have also Dr. Katrina Shea. She's a professor of biology at the Pennsylvania State University. We also have Rebecca Borchering, a postdoctoral researcher at the Pennsylvania State University. I'll also be presenting. My name is Pedro Nascimento de Lima. I'm a PhD candidate at the RAND Corporation and visiting student at Oregon. And finally, we have with us Robert Lampert, a principal researcher at the RAND Corporation. Each presenter will spend roughly 10 minutes presenting their material. Then we'll follow up with a discussion on this important topic. Okay, so with that, Rob, you can take it away.
Okay, thank you, Pedro. And just let me share my welcome to this webinar from the Society for Decision Making Under Deep Uncertainty. Welcome to old friends from the Society. Good to see you, at least virtually again. I just wanted to, and welcome to all those people who are new to our DMDU sessions. And I just wanted to just take a few moments and talk a little bit about what decision-making under deep uncertainty is, since I think we have a number of people who are new to this society and new to this topic. So just in very brief, decision-making under deep uncertainty is a set of concepts, methods, and tools for decision support and informing decisions under conditions where the uncertainties are difficult to characterize with high confidence. And just to give you the definition, deep uncertainty exists when parties to a decision do not know or cannot agree on the system model that relates actions to consequences or the probability distributions to place over the inputs to those models, which consequences to consider and their relative importance. And deep uncertainty often involves decisions that are made over time in dynamic interaction with the system. So decision-making under deep uncertainty embodies a wide range of methods and tools, but they all tend to have the characteristic that they characterize uncertainty with multiple scenarios. And to the extent that probabilities are used, they're often imprecise and then often applied towards the end of the analysis when it's time to differentiate between different otherwise robust options. We often use criteria of robustness rather than optimality to try to find strategies which work over a wide range of scenarios. The idea of adaptive strategies which evolve over time are central because that's often the way you achieve robustness. And there's often an emphasis on using the analytics for rather than for prediction, but rather to help people evaluate and identify strategies that work well over a wide range of futures to help them better manage complex problems. So I'm very excited to kick off this panel today. Much of the work of decision-making under deep uncertainty has covered a wide variety of areas, but often in climate change and natural resource related issues. And it's very exciting to see these applications in the health area and particularly pandemic. So let me send it over to Matthew and let him dive in on his talk.
Hi, good afternoon, good morning, everyone. Thanks so much for the kind of organizers to give me time to talk through sort of CDC's efforts to model the pandemic to help inform decision-making. I'm going to be focusing on sort of our forecasting activities for most of the talk, where I kind of believe we're at the intersection of trying to define some of that uncertainty, but we still exist in periods where we're unable to really, I think, get forecasts that are truly calibrated to sort of the changes that are coming. And so we'll talk through that. But I did want to highlight sort of how we've used modeling during the COVID-19 response to really think about what we do and don't know, and how do we really try to I guess, describe the elephant. And so you'll see we've used it at CDC to help improve situational awareness, and that's where the forecasting fits in that I'll talk through. We also use it to inform the evidence base for mitigation strategies, and then also to synthesize and assess epi characteristics that really do help us understand how we can confront the pandemic. And there's an article linked there at the below that really kind of goes into a lot of examples of how we've used this, that if you are interested, feel free to kind of peruse to kind of walk through that. But moving into kind of the COVID-19 forecasting space, really when we're thinking about sort of uncertainty, we also don't really know which methods are going to be the best at forecasting, what data sources are really going to help make the best forecast. And so we've taken an approach for forecasting that was utilized for influenza and vector-borne diseases to really work in open collaboration with multiple academic and private industry groups to really get forecasts in that are all in the same format, that are using the same target data, that are submitted in at the same time, to really think about which forecasting approaches and methods are doing well, and then also to combine them into ensembles to help also distill all of that information into sort of one message. And we've started this work in April of 2020, and we worked to get total reported deaths per week at the national and state level, newly reported deaths per week at the national and state level, daily new hospitalizations per day at the national and state level, and then newly reported cases per week at the national, state, and county level. And so we built up these sets of outcomes over the pandemic. So these all turned on at sort of different times as new data became available, or as data sort of got validated, or as sort of needs arose, where decision makers really did need to sort of understand where we could be headed for these outcomes. And we work really hard to make sure everything is out in the public in real time, and also to really develop tools that allow people to understand how well these forecasts are doing and when are they appropriately characterizing uncertainty and when aren't they. And I'll walk through some examples of that today. This is just an example of sort of the output we put out each week. I won't go through all of these for time, but we do try to characterize all of this with 95% prediction interval. So we don't sort of focus on point estimates in our forecast, to really also highlight where we could end up over this period. And we try to characterize sort of that uncertainty and sort of, are we going to see likely increases or decreases, instead of saying sort of, what the value will be on certain days. So that's how we've worked to try to bring all of this information in and then translate it to sort of help decision makers work through this. You can see deaths on top, daily hospital admissions on the middle, and then cases on the bottom. And something I want to highlight just before we move on with cases, as we sort of work through and assess the accuracy of these each week, we're also have a system set up to sort of pause the communication of forecast where we see sort of that characterization of uncertainty failing. So you can see on that sort of weekly case forecast at the bottom, we now are only sort of giving a 2-week time horizon. These are based on forecasts we got last Monday. We'll get a new set this week. But now we're only really reporting through December 4th, as opposed to December 17th for the, or 18th for the other outcomes. And that's because we've seen sort of that characterization of uncertainty not match, and we're really not hitting sort of the prediction interval coverage that we would want to have. And so that's one way we're also trying to help decision makers understand that forecast performance. And this is really sort of an example of what I'm talking about with this sort of calibration over time. And this is looking at sort of the mortality forecast. And you can see coverage for that 1-week horizon on top, 2 in the sort of second, 3-week for that third box, and then 4 weeks at the bottom of that box. And so what this coverage metric is showing is sort of how often the observations are falling within the 95% prediction interval. So dots that are on that solid black line indicate that the forecast was calibrated. And we're seeing those observations match sort of that target. On the bottom is the epi curve of incident deaths. So you can see sort of the different waves of the pandemic with the summer, kind of spring, summer 2020 wave on the far left, the winter 2020, 2021 wave in the middle, and then sort of the most recent Delta summer wave to the right side of this figure. And mostly you see this line is flat. We see some dips as sort of deaths go up for maybe the 3 and 4 week horizon, but overall we're often on that black line. And so we don't see sort of forecast having issues characterizing the uncertainty during this period. And this is using the ensemble forecast here, but this ensemble often follows the pattern of the individual forecasts that we get. And just to sort of give you an example of what that means as a decision maker, you can see sort of the observed data here in black, and then what the ensemble was saying that week of where deaths would go, and then what the kind of characterized uncertainty was, just to indicate that often, you know, those points are falling in that, and generally the trends are decently matched. However, when we go to sort of case forecasts, we're at the same sort of setup. Again, the epi curve of cases at the bottom, and then the coverage targets for 1, 2, 3, and 4 week in those sort of rows. And during periods of these rapid increases, we see that the forecast, the ensemble forecast really fails to sort of characterize the uncertainty appropriately. And we're even sort of seeing periods where coverage is near a 0. So the observations may not even be, there may be no sort of forecast that appropriately characterize that uncertainty. And we see this sort of during these periods of rapid growth. We saw it in that winter period, to a small extent in that sort of alpha wave that occurred in spring, but not large scale. And then with this sort of rapid increase associated with Delta, we saw sort of rapid and sustained drops in that coverage period. And so we use these metrics and we try to communicate to sort of decision makers that, you know, there are periods of time when these forecasts really aren't helping us characterize uncertainty. And we probably are moving into a period where, you know, these forecasts sort of represent the most optimistic worst case scenario we can see. And really, it's likely we're going to see things get worse than what is being forecasted here. And we often don't see as much of a degradation on sort of the flip side as we're sort of seeing decreases. We see some drops in coverage, but never quite as much as we're see as sort of on the uptick of the epi curve. And this is just an example of, again, what that actually means for the forecast. You can see sort of that rapid period of cases that were increasing here in the summer of 2021 weren't really sort of projected to occur with that ensemble. And it really missed both the sort of slope and sort of the coverage there. And as we're sort of thinking through, you know, we're using this sort of ensemble. And so what evidence do we have that we should do that, right? How should we really be characterizing all this information coming in? And so we have both information from this pandemic and with our flu and vector-borne work that these ensembles really do perform well. And just what this is showing is sort of the gray lines are all of the individual models coming in. The blue lines are the average of those gray lines. And this is using a metric called the sort of weighted interval score, which is a way to really take in the sort of uncertainty that's being submitted by these forecasts and then scoring that. And so lower values here are better. So if you're at the bottom of these figures, you have a more accurate forecast. The green line is sort of a baseline to compare against sort of persistence, what, you know, if you just projected sort of observations forward, what that would look like. And then the red is the ensemble. And you can see often the red is at the bottom of this figure. So it's the most accurate forecast. And that sort of during these periods of increases, again, we're looking at sort of that October to December period, we see sort of increases in that WIS, meaning all the forecasts become sort of less accurate at this point. But the overall, the sort of ensemble ends up performing the best here. Also just wanted to sort of, as we're a group that likes uncertainty, sort of is there value to get all of these different forecasts in, right? Are we really adding information by having sort of sets of forecasts that maybe aren't performing well overall? And what this figure is just showing sort of the kind of model's distribution of the WIS rank. So if you're sort of on the left of this figure, that means you had sort of the lowest kind of quartile of performance. If you're on the right side of this figure, that means you had the best quartile of performance. And so if you're skewed to the left here, on average, you're probably less accurate forecast. And if you're skewed to the right, on average, you're more accurate forecast. And what you're really just seeing here is that the ensemble is consistently one of the top models across all of these different locations. You know, they're in most of its probability is to the right here. But you can see that even looking across, there's never a forecast that isn't sort of at least in the top quartile across all of these locations. And there are even sort of forecasts that, you know, have these bimodal distributions. They either do really well or they do really poorly, but really just to say, sort of bringing all these forecasts together, we are getting sort of information, and they are adding here and helping us characterize the uncertainty of where we're going in this pandemic. And just quickly, wanted to also highlight sort of when do we think we're at a horizon where forecasts really aren't going to tell us a lot of information. And this just looks at sort of forecasts from 1 week in the future, 4 weeks in the future, and then sort of as you get darker, there are longer horizons. This is looking at the WIS on top and then the prediction interval in the bottom. And this is just to say is we're at these sort of longer horizon periods. We don't really have any sort of long range forecasts that really are calibrated. They're all under the sort of nominal target we would want. And that's really, I think, why we work with the Scenario Hub, which we'll hear about next, to really think about those longer term periods where really we maybe aren't going to be appropriately able to characterize uncertainty, even in sort of the best situations, like we can in some periods for the short-term forecast. So just in conclusion, modeling has been integral to the response, and by bringing all these forecasting teams together, we're really helping, I think, both, characterize where we're going and adding sort of that uncertainty measure there, but we're also able to determine during periods where maybe these forecasts aren't going to be as actionable, and when do we need to think about using other approaches to really help characterize that uncertainty. And with that, I'll end, and I think I'll turn it over to our next speaker. Thank you.
Great, thanks, Matt. I'll just dive in. So that was a great setup. My name is Mike Grunge, and I'm here to talk today on behalf of the Scenario Modeling Hub, which is a companion effort to the Forecast Hub that Matt just talked about. And as Matt said, we're sort of focused on longer range projections on the 6 to 12 month range. And so grappling with this question of uncertainty, when we know, as Matt just showed you, that some of the forecasting methods degrade, you know, after about a month in terms of their calibration. What do we do when we care about things at a longer time frame? So this is a huge effort, tons and tons of partners here. I can't acknowledge them by name all, but really a big collaborative effort here. So one of the things that we've been really focused on here, and this, it's interesting to talk to this society because we're very focused on decision analysis and the decision context in which these projections are used. I've grayed out, I mean, and certainly whether you're talking about sort of classical decision analysis or decision making under deep uncertainty, the grayed out parts really are all the same, right? We talk about problem definition, we talk about setting objectives, thinking about interventions. Ultimately, we think about how that results in decision analysis and implementation. And what we're really talking about in the middle here is how do we develop projections that appropriately incorporate uncertainty. But we're trying to develop those projections with knowledge about how they might be used by decision makers. Now, one of the interesting things about disease outbreak management is sometimes the risks associated with uncertainty, I mean risks in a probabilistic sense here, are actually a central feature of the decision maker's dilemma. Sometimes the predictions of interest to the decision makers are in fact tail probabilities. So I'll give you an example. Suppose you're a public health manager at a county level, and you know how many hospital beds you have in your county, right? So you might be very interested, not so much in the mean prediction or the median prediction of the number of hospitalized patients, but you might be very interested in exceedance probabilities, right? So here, this was some work we did last summer, early in the pandemic. This is a cumulative probability distribution that's trying to capture uncertainty about what the peak hospitalized cases will be. You can see, if you're good at reading cumulative distribution functions, this is kind of weirdly bimodal. The median is 190 patients that need beds. The mean is 350. But interestingly, those don't have, if you've got 500 beds, the thing you care about is what's the probability that the peak hospitalization will exceed 500 beds, right? And that in this particular case is a 38% probability. So in this case, the tail probability of this projection or prediction is actually the relevant feature to the decision maker and might lead them to do something different. And so so there are cases when probabilistic estimation of risk matters to the decision maker. Okay, but as Matt just talked about, what do we do then when at the relevant timescales in order to be able to implement action? Uncertainty is quite hard to characterize. This is a little diagram just contrasting how we're using the term forecast, as Matt was talking about, differently than the term projection, which the Scenario Hub has been focused on. We've been thinking about projecting cases, hospitalizations, and deaths over 6 to 12 months, knowing, however, that the challenge of fully incorporating uncertainty into those forecasts, into those projections is difficult. So the way we've done this in the Scenario Hub is kind of a hybrid between sort of a classical treatment of uncertainty probabilistically and a deep uncertainty treatment. A typical round for us in the Scenario Modeling Hub, we don't do them weekly. We don't do a new set of projections weekly like the Forecast Hub does. They tend to be every 4 to 6 weeks. These rounds, have a design. You typically, as shown here, we'll have a sort of 2x2 matrix. And often one of the axes is a decision axis. So in this case, this was round 9, which was produced in early September. This was prior to authorization of vaccination for children. So one of the decision axes we're looking at is, well, what if there's no vaccination for children under 12 over the next 6 months versus what if there is? What if vaccination is approved around November 1st and then we have some assumptions about what the uptake rate would be in children as compared to teens. So you've got a decision axis in this table, and then you've got an uncertainty axis that had to do with, are we going to have the same mix of variants circulating through the projection period, September through March, or will a new variant emerge, say around November 15th, that's 50% more transmissible than the Delta variant. After this weekend, this is looking weirdly prescient. But we don't know, we didn't know at the time in early September whether there was no variants on the horizon that people had named and were worried about, but we were just set as sort of a stress test, as a robustness test to this question about vaccination. What would happen if, okay? Now, what we do that's sort of the hybrid treatment of certainty is within these scenarios, A, B, C, and D, we work really hard to describe things probabilistically. But between the scenarios, we don't sign a probability to A, B, C, or D. We don't treat those probabilistically. We treat those as if those are sources of deep uncertainty. But within the scenarios, we work really hard to characterize uncertainty probabilistically. I will just, as a side note for the decision analysts, and I know most of you out there are, notice that this structure, it does look like an expected value of perfect information structure where you've got a decision on one axis and uncertainty on another axis. So you could ask what would be the value of resolving the uncertainty if you're interested. Okay, so within scenarios, so we really work hard to estimate the uncertainty within scenarios, and we do it the same way that the Forecast Hub does. We've got multiple independent modeling teams that are using their expertise to project the epidemic under the descriptions of each of the scenarios. Each of those models provides a full probability distribution at each point in time for each of the outcomes. So we're asking them to make probabilistic predictions conditional on the scenario description. Drawing from the literature on expert judgment, we certainly expect the individual models to be overconfident, making the between model variation very important, and it is to us. And so like the Forecast Hub, what we do is form an ensemble projection for each scenario. And we find that those ensemble projections are pretty good. So this is the round 9 childhood vaccination, where childhood vaccination is implemented and there's no new variant. And okay, so this is so far what has in fact happened, and the dots show the observed values since the projections were made. And so I think we had 8 or 9 models in this round, and you can see their individual probability distributions in the different colors, and you can see the observed values coming through there. That central solid line is at the ensemble median. So okay, so that's what we do, to probabilistically describe uncertainty for scenarios, that is conditioned on the scenario description. And then across scenarios, we just stack those up and let the decision makers see those, and we don't ascribe any probability to them. So in this round 9, we had these 4 scenarios with and without vaccination, with and without an emergent of a new variant. These are the projected cases for the 6-month period with the 95% confidence intervals for the ensemble. I'm not showing the individual models now. So this is the information that then, really becomes most visible to decision makers. Now, this was presented to the CDC at the time the scenarios were developed. The FDA and the CDC had not yet authorized vaccine for children. Our estimate was, in the absence of a new variant, that the vaccination of children 5 to 11 years old would reduce US cases by about 7.2%. If a variant came along in November and it was 50% more transmissible, okay, these are the things that are not easily knowable and not easy to describe probabilistically. But if it did, and it met the kind of descriptions that we gave in those scenarios, childhood vaccination would have a stronger effect. We estimated it would reduce 10.1% of cases, not just in children, but across all age groups in the US. This information was presented to the CDC's advisory committee at the time that they were considering the childhood vaccination authorization. They had this information. It was one of the things they weighed in the decision making. Anyway, the point I want to make is, we've got these individual scenarios that we describe probabilistically and work really hard to do that. And then we've got multiple scenarios in a round, which are sort of representing as best we can some of the key components of deep uncertainty at the time. So we've done 10 rounds in the last year. They've covered everything from early on. We were worried about vaccine supply. Boy, that's a non-issue now, right? We were worried about the Alpha variant. It was like vaccine supplies and non-pharmaceutical interventions. That was a big focus for the early part of the year. Now came along, we're looking at that, and vaccine hesitancy. The Delta came along, we're looking at that, and vaccine uptake. Then the childhood vaccination. Right now, we're focused on the question of immune waning and boosters and the effect of boosters. That work's in progress. We might release those results next week. I mean, when we look over the course of the last year and how these projections have done, some rounds have done great, and there's at least one scenario within each round that has sort of tracked reality pretty well. Others not so much. This first round one, we thought things were headed out of control across all the scenarios we ran. Well, no, there was one scenario. Actually, there was one scenario in that was coming down. And okay, so we tracked that one okay, right? But you can see some of the times, across the scenarios we want to run in a round, reality falls within those bounds, the bounds of deep uncertainty that we express. Sometimes not. So anyway, it's sort of interesting, and we're constantly going back now and looking at when do we do well, when don't we do well, and what's driving that, and can we learn from that. So okay, just to summarize a bit, we do find, like the forecast published found and other efforts have found, that the multi-model approach, multiple independent modeling teams doing common forecasts or projections. That approach generates significant insights. First of all, just the conversations are profound. Significant insights into sources of uncertainty, and makes both the individual models better and the ensemble better. So that's good. At the relevant timescales, 6 to 12 months or 15, we remain overconfident. Now at the conditional scenario level, right, if we get the scenario conditions right, our ensembling method works pretty good at capturing uncertainty. So I think the probabilistic approach, conditional on getting the scenario description right, is not bad, right? And we've worked pretty hard at that part. But our scenario specifications, as you would imagine, right, since the deep uncertainty piece, are sometimes too narrow. We kind of miss the delta emergence or the strength of the delta emergence when it occurred. decision makers are asking for and acting on these projections. We're getting requests right now for round 10 from decision makers. Risk matters, right? I think that although the decision makers aren't asking for the probabilistic descriptions, risk does matter, and they are thinking about risk and uncertainty in their decisions. They don't, I think for the most part, most of the public health agencies don't have a formal decision analytical structure for evaluating risk tolerance and trade-offs. They're not using formal decision analysis methods, but they are very interested in the description of uncertainty and then themselves doing this sort of narrative analysis of risk as they make their decisions. I think reasonably, so there's a lot of communication questions here that are really hard. Certainly, I think a reasonably good discussion of uncertainty by the scientists matters for their credibility, right? If you don't discuss uncertainty and you're not pretty good at capturing the range of possibilities, then I think credibility of the projections or forecasts is undermined. But I think we have a lot of work to do to better understand why we're surprised what I think is too often. I think these are not black swans that are surprising us. I think it's largely our failure to codify the kinds of uncertainties that we do in fact know about. And so, there's challenges to continue to figure out how to get better. So I'll stop there. I just want to thank all the participating folks that have been part of this effort. Thanks, and I'll turn it back to Peter.
Okay, thanks, Matthew and Mike for their presentations. So I'll be very brief with my presentation. In this brief talk, I will explain the key findings from 3 recent papers or publications that we put out recently. One is about stress testing reopening plans and stress testing California's reopening plan. Then a brief summary of the findings from that paper, and also a more recent archive paper that Sarah Nowak led, and Raf and I worked together on this, and that is exploratory in essence, but also shed some interesting, generated some interesting insights about the shape of the policies. So I think it's interesting that my talk complements the previous ones, because we're going from the short-term forecasting in the short term and addressing uncertainty to a medium range, few months ahead, to a point where we really want to stress test our policies throughout many months into the future. So this work is based on our prior work, which was a tool that we released in the beginning of the pandemic to show us reopening scenarios and to illuminate certain trade-offs that we observed at the time. And so our work is really a follow-up on that initial tool. And the question that we're really interested, not only for California, but for other jurisdictions, was how to manage non-pharmaceutical interventions in 2021 amidst uncertainty, right? So at that point, we had these reopening plans, and we had many uncertainties being created, right, by the environment and by our behavior. We had new strains coming up, we had vaccination starting, and really the question was, how stringent should these reopening plans be? What restrictions should apply to each level, and how these restrictions should be managed over time, contingent on other conditions. So the question is, are we following a robust strategy? Is this strategy Pareto efficient? That is it making no one unnecessarily worse off? And you might think, well, this is really a question about the past, but if you look at what's happening in Europe, in the Netherlands, we still have countries imposing non-pharmaceutical interventions. So this is still relevant. So the key question here was really, what is our long-term strategy with these non-pharmaceutical interventions? Are we following dominated strategies? And most importantly, can we find robust strategies given the problem structure, as opposed to good predictions given our assumptions? So that was our motivation for this work. And this work is spread in a few publications. So if you want to know the details of our model, there is a publication for that. If you want to learn and read the robust decision-making analysis we performed. There's a paper describing this analysis. And if you're just interested in the key policy recommendations, we also published this perspective laying out the 4 ingredients of the policies that we found were the most robust. So this audience is probably very familiar with the RDM approach. I will not dwell on this slide, but just for those who do not know RDM, robust decision-making is an approach that is used to stress test adaptive policies, and it has been used in many different fields in climate change, and it really provides an iterative framework for evaluating policies, accounting for deep uncertainty, and improving the quality of the policies, even when we don't get very good predictions. And the key outputs of the RDM process are decision-relevant scenarios and robust strategies. But I will not dwell on this topic. And the paper that I will talk about in the beginning is the Reopening California paper. And this figure codifies the rationale behind that paper. So in that paper, we are stress testing a pandemic control loop, which looks pretty much like most reopening plans that are based on the number of cases, right? So if you think about the society structure in terms of infectious contacts, you can think about this as a mixing matrix. And infectious disease modelers know this very well. We characterize in heterogeneous systems, we characterize infectious through these matrices where we characterize how much people are mixing in the household, in the work, in the leisure. And when we have an intervention, what we're doing is cutting these connections, cutting these connections in this network. And when we do this, this affects the disease progression. And this is just a picture of the disease progression model. And the way that this pandemic control loop works is that we observe prevalence, we observe COVID-19 cases or deaths or hospitalizations, and then we instate non-pharmaceutical interventions. And then this simple formula is used in our model to determine the level of the NPI. So a high NPI level means that we are doing more to suppress the pandemic, and a low means that we're doing less. And there is a key variable in our model called the level of caution that determines how aggressive we are in trying to curb this prevalence. And the challenge in setting up this control loop, as you can imagine, is that there are many things that are shocking the system. We have new variants, behavioral changes, we have multiple vaccines with different efficacies, people have different willingness to vaccinate, and so on and so forth. So the decision challenge is, how do you manage this system? How do you control this pandemic, given all these uncertainties, how do you do that in a way that minimizes all the bad outcomes from the pandemic? What's interesting about this setup and infectious disease modeling in general is that there are many known mechanisms. So as Mike said, these are really not completely unknowable uncertainties. We know how transmission works. We know how the disease progresses. We have a good way of looking at cases, and we know how the non-pharmaceutical interventions affect those transmission links, right? If people don't go to work, or if we shut down businesses, we're shutting the transmission paths at those places. So we know many of the mechanisms. So still, mechanistic models can be useful for computational experimentation, even when prediction is not even when long-term prediction is not available. And the policy question and the way that we set this up in our paper was, how do we manage this level of caution over time, given that we're rolling out vaccines, right? So we have a few options. We have a constant caution approach, we have a time-based approach, we have a smooth function of vaccination. And you can find the details of that set up in our paper. But really the question is, how do you manage the system over time, over a long time horizon, long meaning 1 year? And in our paper, you will also find the uncertainties we consider, the policy levers, the relationships, and the metrics. If you think about the relationship of this approach with what Mike and Matthew explained, It's actually very similar. So we calibrate our model in the past, we get a posterior distribution of parameters, and then we create alternative scenarios deviating from that baseline distribution. And we do that considering a set of uncertainties, including vaccine efficacy, loss of immunity, behavioral response to vaccination, and so on and so forth. So these uncertainties encompass some of the scenarios that Mike presented. Okay, and I would just give you a hint of what is in the paper. So if you look at each experiment result, it is plotted here as a point, and the colors in this plot represent the percent change in transmissibility, for example, as a result of a new variant strain, and the columns represent different strategies. And these strategies to the right are the most stringent. These are the less stringent, and they are all constant threshold strategies. And what you can see is that these strategies can bend this curve between NPI days and deaths to regret in a way that if we pay a higher price for reducing deaths, we can do that, of course, at the expense of more NPI days under interventions. And if you try to simplify this in a two-axis plot, this is what you can come up with. And each point in this plot represents a different strategy. The shapes represent different types of strategies. What we found was that strategies that used a baseline level of caution, the circle strategies, were systematically dominated in this analysis. So if you take the baseline strategy that we considered, you can find many strategies that can result in a lower number of deaths and lower numbers of days under NPIs, accounting for robustness, of course, of these two metrics. So this justifies why many reopening plans were changed over time. And what we found is that actually starting with a more stringent plan and relaxing this plan over time does make sense. Well, okay, so what are the ingredients of these robust policies? And that's what we have in this other perspective. We just summarized 4 basic ingredients of reopening strategies, and you may think that they're simple, but you would be surprised if you look at reopening plans and actual realized reopening strategies, and you see that many of them don't include all these ingredients. Okay, so moving forward, one of the questions that we had after doing this was, should we do this again, right? If we had a new, different pandemic, right? A different cost of social distancing or different cost to mitigate and different death rates and so on and so forth, should we do this again? And that is the question that we had with Raf and Sarah Nowak. And we set up this exercise in which we have a rational, hyper-rational society, meaning that everyone has an SIR model in their heads and behaves rationally. The society is trying to minimize the pandemic cost, meaning it's trying to minimize cost of infection and cost of the non-pharmaceutical interventions jointly. It has a fixed time horizon, and it's constrained by the standard SIR dynamics. And we codify these assumptions in a mathematical model and solve that as a boundary value problem. And the question we had was, which strategies emerge from this problem and which strategies emerge from these structural assumptions? Are they like those strategies we test for COVID? And more importantly, under which conditions do we sustain this strict suppression strategy? And what we found was that depending on the conditions that you subject the system to, you get very different strategies. And the higher the cost of social distance, the higher the time frame of the pandemic, you get strategies that are more relaxed. If you get a situation where you have lower cost of social distancing and shorter time frames, for example, to develop a vaccine, you get strategies that are pretty strict. So this resonates with what we did. There are also a few points in that paper to be read. Okay, so with that, I will stop here and turn it over to Rob to see if we have any questions.
Great, thanks, Pedro. Thanks, Matthew, and thanks, Mike. Do we have any questions from the audience?
Hi, this is Doug Samuelson, Infologics Incorporated, Annandale, Virginia. Were there, we know that from time to time it came to light that some fatalities had been undercounted, in particular the nursing homes in New York State. Was there any effect to going back, readjusting the actuals and then recalibrating the models?
I mean, I can take a kind of a first pass at that, and then maybe Mike or Pedro, if you want to jump in. I mean, I think sort of the whole data like inputs for the forecast is, I think, a large area of the work in this space to really understand sort of how the data gets into the system, who's counted, and then sort of how the actual reporting behavior changes over the pandemic, and then really working to sort of help explain that to the people making the forecast or these model projections, and making sure that's sort of an iterative process, because these data are constantly evolving and how they're collected and being reported. And it's really important for people to know if there are sorts of large backfill events occurring, or if there are large delays associated either with holidays or because we're in the middle of a surge and capacity to report becomes sort of diminished and reduced. And so we do work a lot to sort of explain these data processes. And then we also have partners at Johns Hopkins. The CSSC group works really hard as well to sort of understand the reporting system and making sure that information is available as people sort of calibrate and make these forecast projections each week. So it does impact. I mean, we know when we see periods of large backfills, we see degradations in forecast accuracy sort of for weeks after that. I imagine that's happening with these scenario projections as well. I know a story of when we sort of shut, one of the projection periods off right before the July 4th holiday, that sort of caused some issues in that round of scenario projection. So it is really important to have good awareness of that.
Any other comments from any of our other panelists? If not, I think we have a question from Mikhail. You want to ask a question?
Yeah, thanks a lot. Thanks a lot for the great presentations. I have a question for, I guess, two first speakers. So when you're dealing with the ensemble of models, like, do you treat all of them equally, or do you assign a certain weight to the outcomes of a single model based on some certain factor? So how do you come up with this better understanding of the spread of the disease given different models?
Yeah, I can start with the forecast there. So we actually are sort of using hybrid approaches now. So for the case and hospitalization forecast, we're using an unweighted median. So we're bringing all the forecasts, and then they each get equal weight regardless of past performance there. But for mortality, we're actually weighting based on past performance. And so we have every week sort of an iterative weighting process that takes sort of the top 10 best models and then weights them based on the weighted interval score that I mentioned. And we've been evaluating different methods for making the ensembles basically since we started making the ensemble. And we have a lot of evidence that weighted approach works really well for mortality, but actually hasn't worked as well for cases and hospitalizations, and the median approach works better there. So that's something we look at every week, and we've evaluated other approaches as well. But it really is strikingly difficult to beat that median weighted ensemble that really has takes no information about past performance in there, but it is possible to do that. Mike, I don't know if you want to take the COVID.
Yeah, for the scenario hub, it's been a little bit different. I mean, the forecast hub that Matt was talking about, they've got weekly forecasts, and they've got about 30 or so modeling teams. So there's sort of a lot of data to use to sort of evaluate forecasts, and they're short term. So you get to do the observation fairly quickly. Because of the way the scenario modeling hub works, some of the scenarios don't ever unfold. So we can't even use those projections to sort of evaluate past, we can't use those observations to evaluate the projections. So we don't have as much data to use to sort of feed back to do a weighting scheme. But we've thought an awful lot about how we compose the ensemble. We actually use a slightly different ensembling method. We use a linear opinion pool, whereas the forecast hub uses a Vincent's average. and we've played a little bit with whether we trim before we take the ensemble or not, and we're in the middle of a lot of sort of evaluation of those kinds of things, but we haven't looked at actually weighting the individual models other than whether we include them in the ensemble or not. So it's a sort of open part of the challenge, and something we spent a lot of time thinking about.
Okay.
I think I was just going to add, I think one of the issues is that we, with the scenario hub, the scenarios are different every time. So when we compare how the performance of any individual model compares to the linear opinion pool, we often find that there may be one that does better than the linear opinion pool in a given round, but it won't be the same model in the next round. So across rounds, there's no opportunity to learn. But if we were doing repeated scenarios, we could do something where there was some sort of learning, but all the models are changing every round as well. So when you call model A in round 1 is not necessarily model A in round 10, because it has also changed through time. So there's a lot of different things, a lot of different moving pieces that make it really hard to do any sort of more formal validation. And so for now, we're not doing any weighting. But you could, if you were doing repeated rounds, move into some sort of more adaptive management type framework.
I was going to ask, I suppose start with the scenario hub people. How do you guys choose the scenarios, and to what extent in your interactions with decision makers are they asking you to interrogate or provide information for specific decision choices, A versus B, and to what extent are they just asking sort of a more constant general set of questions?
Yeah, it's been interesting. And so the design of the scenarios, that process usually takes about a month of conversation, sort of leading up to initiating a new round. And it's conversation we're having with the CDC or with folks in the White House or with public health agencies at the state level. And the modeling teams are engaged in those conversations as well. And each of the modeling teams, and there's about 10 or 11 or so that are part of our conversations, they all have ties to decision makers. Like there's one team that's really close with the say the Michigan Department of Health or the New York Department of Health or the Massachusetts Department of Health. And so we're getting kind of input in an informal way, but most of our conversations with the CDC, they're not asking the same questions every time. It's definitely the case that the questions are evolving. And I'm pretty sure that the conversation we're going to have in about a week's time is, what is the potential effect of the Omicron variant? I'm almost sure that's going to arise. And so, we don't have a formal process for exactly how those scenarios are developed. But the decision questions they're asking, you saw like the vaccination question, the specific vaccination questions are very timely. And so that's happening. And then also, what are the uncertainties that are most worrying the epidemiologists, the public health professionals? Those conversations are happening as well. And it just sort of eventually emerges, at the end of about a month's conversation about how we're going to design the scenarios.
I think an issue is that because there are so many different stakeholders, there are multiple objectives every time. And so the group is pulled in a multiplicity of different directions. And for logistical reasons, we've restricted ourselves to 4 scenarios, whereas, Pedro did, every cross of every possibility, because you're doing it within your own model. And we could do that, but we have some models that are individual based models that just take absolutely ages to run. And so this was what would engender buy-in with, but also make it useful. So we've restricted ourselves to 4, but it would be possible to do more or do more more formal analysis. Because one of the things that just keeps resonating with me is the projections from these models will be all over the place, but often the rankings are incredibly consistent about actions. And yet we are often not able to sort of encourage a decision-centric approach. There's Matt talked about it. There's a very great interest in situational awareness, like what is going to happen. Still very much as if we're forecasting the weather rather than having agency over these things as true decisions that we could make and change the pandemic's course. So it's a really interesting discussion because people are coming from such different points of view.
So it's more an institutional limitation at this point than actually an analytic one. I mean, there's sort of the way the conversation is structured.
I wouldn't say limitation. I would just say the focus is very much on providing information to so many stakeholders in so many different forms that it's very hard to pin down even enough objectives for a sensible multi-criterion analysis.
And I think it's interesting how sometimes it's not a direct intervention per se that the scenario is directed at, as more of a how bad could it get? How can we communicate at more of an individual level to sort of influence people's behavior indirectly?
Interesting. We're coming to the end of our time. I think we have time at least for one more quick question. If anybody has one from the audience.
I do have a question.
Great.
I'm not exactly sure which speaker to address this to, but thank you all for the presentation regardless. And so when considering the different reopening strategies and their robustness, could you just talk a little bit about your strategy for creating those, your methods for creating those strategies? Were those like solicited from stakeholders, or where did they come from?
Yeah, I guess the question is directed to me. So in that case, in the reopening California, we really started from what California was doing, which was have these reopening plans with a few levels, and the way that we coded our strategies, trying to mimic what California was doing as much as we could with a simplified model. And then from that point, how would you change that? And at that point, the question was, well, when do we relax? And then we created alternatives that started from that baseline. So that was our approach. It wasn't elucidated, and it turned out to mimic what we ended up doing. But it was starting from where the strategy that we were following at that time.
I have a question for Matthew.
Okay, Warren will question, and then we'll end the session.
Okay. I am delighted to see that the CDC is using DMDU methods, but what I'm very frustrated at is the fact that the decision-making around the pandemic is so fragmented in the United States that how is the CDC trying to coordinate?
Yeah, that's a great point, right? We're in a federalist country, so we have lots of different states and actors in those states that make these decisions. And so what we do is we fund academic groups and also have a set of collaborators across the states that we meet with monthly to discuss these methods and to show these results. So we at least are helping bring different state partners together in this modeling and forecasting space to really hear what questions are coming from there, if they have questions about the methods that are being used to answer these at the kind of federal level. And so we're trying to create sort of that set of conversations in the modeling and forecasting space and bringing the sort of state and locals together with the academic groups. That's one way we're trying to address sort of our fragmented decision-making approach. But I think there are other efforts across the response and in the US government to really, I think, bring the people who make these decisions together and work, I think, towards helping provide that evidence that can make that policy. But that's at least one tangible way is through our work with the Council of State Territorial Epidemiologists on that.
Do you see governments and local governments, state governments, people listening to you?
I think we definitely have a lot of engagement, and people are quite interested. The epidemiologists and other health officials, and Rebecca and Pedro and Mike. A lot of you have been on these state calls as well. I think there is a bunch of interest in understanding the sort of information coming out of these models or the forecasts, understanding how they're made, how they can be applied at the local level. I think where we all have challenges is you can have sort of the best evidence to make a policy, but then you have to convince sort of people to follow those policies, right, in the wider population, since all of this is basically voluntary action at this point. And so I think that's where we're having a lot of challenges, and where I think further work in sort of that behavioral modeling or sort of understanding personal decision making can be really helpful as an integrated part of this EPI and forecast work.
Good luck. Thank you.
Yeah. So with that, thanks to our speakers, and thanks to the audience, and great session, and thanks all for joining us.
All right. Thank you, everyone. Thanks,
okay.
Matthew, Rebecca, Mike, Katrina, for joining us.
Okay.
Very nice.
Bye-bye.
Bye.